Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. So glad that you could join us today. Our guest in studio today is Professor Joanna Kempner. She basically works at the intersection of medicine, science, gender, and the body, with research focusing both on the formation of social problems and on ways in which some issues are consistently ignored, dismissed, or delegitimized. She's the author of a book, Not Tonight, Migraine and the Politics of Gender and Health. She received her PhD from the University of Pennsylvania. Prior to joining Rutgers, she was a fellow in the Robert Wood Johnson Scholars in Health Policy Research Program at the University of Michigan, and she was also a research associate at the Center for Health and Wellbeing at Princeton University. She's here to talk with us today about chronic pain, specifically migraine, and the politics that surround such pain. How are you doing today, Professor?
I'm doing great. Thank you so much for having me.
When it comes to pain, whether it be chronic pain or not, there seems to be, especially in recent years, a huge, for lack of a better term, political agenda when it comes to managing people's pain. And I'm talking about not the patient managing their pain on their own, but the healthcare institution or the government managing their care in the way that they feel that it should be managed. You are the author of a book called Not Tonight, Migraine and the Politics of Gender and Health. I may be one of the few people that did not associate it with migraines, and I think it's because of my own experience, knowing that migraines are much more serious than just a simple headache. Could you talk a little bit about the book and why you wrote the book?
Sure. Well, everyone in my family has migraines. My mom, my dad, my grandmothers, and I had migraines since I was a little girl. And so I know how debilitating migraine can be. I grew up with a mom who spent days on end in bed, and now I'm a mom myself, and I have to struggle to take care of my kids, even though I'm often sick. And I'm not alone. Migraine is one of the most prevalent disorders in the population. It affects upwards of 12% of the population.
That's huge.
It's huge. It's huge. So it's amazing to me to think that people out there think migraine isn't a big deal when in fact migraine can be and often is devastating. And I'm glad that you brought up the way that the government is involved in pain care and the institutional influences in pain care, because there are really intriguing paradoxes there. On one hand, we have this opioid crisis where we have a kind of almost an overtreatment of pain that's leading to this opioid crisis. But it's not really so much an overtreatment of pain. It's the poor treatment of pain. We don't have good pain medications. Migraine doesn't really respond to opioid. And so, with all the money that we spend on certain kinds of pain treatment, we don't really have effective treatments for migraine. So some kinds of pain treatment get a lot of attention. Some kinds of pain treatment get no attention. And in the meantime, our country has this unbelievable opioid crisis, which I think is in part created by the fact that we don't have effective pain treatments. And so people are looking to numb their pain any way they can.
When it comes to determining what is real and what is not real when it comes to pain, what are some of the criteria, and does migraine meet that criteria?
So I think in medicine, the gold standard for deciding whether or not something is real is being able to see it, right? Being able to visualize a biological pathophysiology, right? So your best case is something's visible. You see a gallbladder stone or a broken bone, or there's a tumor pressing on a nerve, something really obvious. The second best thing that medicine can come up with is something we can infer a biological pathophysiology from. So maybe your pain responds very well to a specific drug, or maybe it shows up on a brain scan, or in the absence of even that, we can argue, well, we can't really identify a cause of this pain, but we know it creates some tangible economic or public health burdens. So we have to do something about pain generally.
Well, I was thinking about, when it comes to this chronic pain, these migraines, I've heard it said that migraines weren't real, that they're in the mind. I've also heard that there are so many different opinions as to what causes migraine in the first place. Isn't not being able to be treated effectively for migraine or other types of chronic pain, isn't the fact that you can't be treated for it effectively based on the fact that we don't tie down this pain to a specific cause or a specific treatment, or do we just say, hey, I don't understand it. We're going to let it go, and they're just kind of on their own? Because I've known some people who suffer from migraine who are basically on their own until they find a physician who understands that it doesn't respond to opioids, well.
It's kind of funny the way medicine deals with the cause, how we understand cause, because, you would think that the way treatment works is first you would find out what causes a disorder, and then you would develop a treatment for it. But that's not actually how medicine often works. Often what happens is we find a treatment first, and then from that we infer the cause. And you can think of lots of disorders in which that's the case. But for migraine, what's happened is we have some treatments that are pretty effective. So, for example, sumatriptan is a drug that is fairly effective for some people with migraine, and it is a serotonin agonist. And so from that, there have been a number of theories about the role of serotonin, the role of neurotransmitters in migraine. So it works backwards sometimes from treatment back down to cause.
You say that you're a sociologist of medicine. When it comes to the sociology of medicine, I think we touched a little bit about on some of the financial aspects of pain and debilitating diseases. They affect our society in negative ways across the board. But when it comes to the government being involved and trying to determine what type of treatment, who gets that treatment, and for how long they can have that treatment, it sends up kind of a scary red flag as to, well, is there an agenda or is there no agenda at all? And which is worse?
Well, I think with migraine, it's just something that's very much overlooked. It's not seen as important. And one of the things I think that drives that agenda is patient advocacy. So migraine is not only is it an invisible disorder, but even though migraine affects such a large portion of the population, up until very recently, the patients who have migraine have been largely invisible to the government. So they haven't really been pushing the federal government to fund migraine research. That's starting to change.
So the awareness of migraine and migraine research is starting to become more prevalent in the general medical population. Yeah.
I hope so. I'm certainly encouraged by recent efforts for people with migraine to go down to Washington, to tell their legislators, to tell people at the NIH what the burden of migraine is, how it affects people, individuals personally, what the public health burden is, and to encourage increased funding for migraine. Right now, the funding for migraine averages annually from the NIH at about $20 million a year. For NIH, that is a very, very low rate of funding for a disorder that's causing about $30 billion a year to the U.S. economy.
As far as lost wages and healthcare burdens?
Exactly.
When someone tells their physician that they're suffering from what they believe to be migraines, how does a person know that they're suffering? I mean, short of a head injury, how do you know when you're suffering from a migraine headache as opposed to a tension headache, or you're about to have an aneurysm? How does a person tell, and can a person tell, or is it something that has to be diagnosed by a professional?
Well, that's a very good question. There are no objective tests, no objective diagnostic tests that can tell you whether or not you have a migraine. This is one of the problems with legitimacy for migraine. And there's a very big problem with underdiagnosis of migraine in this country. Something like half of people with migraine don't have a diagnosis of migraine. The diagnostic criteria of migraine typically consist of, you don't always have to have a headache, but a defining characteristic of migraine is typically a headache accompanied by nausea, light sound sensitivity, and other kind of autonomic features, although I should say I'm not a doctor. But you should, if you have a headache that comes out of nowhere, it's most of your headache you've ever had, you should definitely go see a doctor. And, yeah.
Now, as we wrap up this segment, where can our listeners get a copy of your book and more information on you?
The University of Chicago Press sells my book, as does Amazon or any major book retailer.
Okay, great. And do you have a website that we can visit?
Yes, you can learn more about me at www.joannakempner.com.
Great. You've been listening to Health Professional Radio. I'm your host, Neil Howard. It's been a pleasure talking with Professor Joanna Kempner in studio today, talking about the politics of chronic pain, in specifically migraine headaches. We've been talking about some of the reasons that this chronic pain has been overlooked and underdiagnosed and often controlled as far as medicines that could help by the government. Lots of red tape and hoops to jump through before it's admitted by the medical community that someone is suffering from an actual migraine headache, as opposed to just a simple tension headache or some other type of headache. Professor Kempner received her PhD from the University of Pennsylvania, and she is currently working on several projects related to the politics of disease and the sociology of medicine. It's been great talking with you today, Professor.
Thank you.
Thank you so much. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. And you can subscribe to our podcast on iTunes.